Yeah, so CD7 is an excellent target in T-cell ALL. It's expressed very brightly, uniformly in most of the cases. It is frequently downregulated in mature T-cell neoplasms, such as peripheral T-cell lymphoma. But for TLL, it's among the best, if not the best target. And so, developing CAR T-cell approaches for this disease obviously makes a lot of sense. Now, unlike CD5 that are automatically fratricide resistant, for CD7 CAR T-cells, we have to do something else. We have to either CRISPR it out, or we can use protein expression blocker to remove surface expression. Or the approach that we have recently developed is not to do any of those and instead just expand them in the presence of pharmacologic inhibitors of tyrosine kinases that block that signaling. And as a result, we can generate the products, the T-cell products that are quite functional. And there have been several clinical trials so far of CD7 CAR T-cells using different cell sources, autologous, donor-derived, off-the-shelf, allogeneic cells using different strategies to prevent fratricide. Again, CRISPRing them out or blocking with an additional construct that anchors CD7 inside the cell. And both of these lead to very functional T-cell products. And there have been a few studies primarily coming out from our colleagues in China that show very good activity in patients with refractory and relapsed T-cell ALL as a bridge to hematopoietic stem cell transplant most of the time. And our own clinical experience shows that cells that are unmanipulated, unedited, and expanded with tyrosine kinase inhibitors also produce very good responses, at least on dose level 2, and we continue escalating that. So also an important aspect of that is aplasia of normal T cells is limited because of the normal subsets that are naturally CD7 negative that repopulate the host, they expand, and we tend to think that they mediate protection against systemic infections. So the safety profile is pretty good for that.